I'd like to welcome all of you to the Clinical Updates and Immune Therapy session. My name is Heather MacArthur. I'm the Clinical Director of Breast Cancer and Komen Distinguished Chair at the University of Texas Southwestern in Dallas, Texas. And I'm joined today by my friend and colleague, Professor Peter Schmidt from Bart's Cancer Institute, Queen Mary, University of London in the UK. Peter, are you with us?
I hope I am. Good morning, good evening, wherever you are in the world. It's a pleasure to be with you virtually today. Unfortunately, we all sort of on different continents today, but nevertheless, this connects us with a great program together today. So as Heather already said, the session is on clinical updates on immune therapy. We have a great faculty together. We first have a talk on the metastatic setting, then we have a talk on the early setting in triple-negative breast cancer. The last talk will look into immune therapy beyond triple-negative breast cancer. So it's my pleasure to introduce the first speaker tonight, Rebecca Dent, a close friend of mine from Canada, who now works in Singapore, as a Chairman and Senior Consultant, Division of Medical Oncology at the National Cancer Center in Singapore. Rebecca will talk about immune therapy in metastatic triple-negative breast cancer with a special focus on the chemotherapy backbones on what biomarkers to select. Rebecca, over to you, please.
Thanks so much, Peter, and delighted to be with you all virtually. Thanks so much for the kind introduction and really look forward to the discussion. So as you mentioned, I'm supposed to review for you today immunotherapy and metastatic triple-negative, which backbone and biomarker are best. These are my declarations of interest. So I think it's important to first recognize, why was triple-negative identified early on as a subtype of breast cancer that might be particularly susceptible to immune checkpoint inhibition? And the first really is its higher mutational rate. The second thing is really looking at its higher rate of T-cell infiltration, and finally, higher rate of PD-L1 expression. Now, ironically, now that we've had some time, we realize that in fact, the immune portrait of triple-negative is much more complex than we ever imagined. And so now we're identifying things that make these tumors more sensitive, but also resistant, and identify the early progression to immune escape. So this is the clinical scenario, because I think, in these education sessions, I think what's first and foremost is to figure out how we can incorporate the current data into clinical practice, but also to get a sense of where the field is shifting so that we can figure out how do we incorporate some of these agents. So I want to start off with a case of a 45-year-old patient who was treated with an anthracycline taxane platinum combination for a clinical T2N1 grade 3 triple-negative. And as many of you agree, we often treat these patients now with neoadjuvant therapy. She had a great clinical response, had a residual 1 centimeter of disease, and was treated with adjuvant capecitabine. Now, a year and a half later, she has new onset shortness of breath. Her staging reveals lung and liver lesions, and a biopsy of those lung lesions confirms a high-grade triple-negative breast cancer. So the first question is, what biomarkers do we want to test for? And ironically, what is our turnaround time, and how available are some of these biomarkers that we want to do? And I think, as Jack West recently said on Twitter, the most imprecise thing about precision medicine is the turnaround time. So I also want to comment that this is, a patient that many of us would see in clinic, but there are a number of new treatments now that are available to us. So this patient now in our clinical practice would likely be offered neoadjuvant pembrolizumab based on the KEYNOTE-522 data. And then we would be in a quandary with her residual disease. What shall we give her? If she was a germline BRCA carrier, we would also have the option of giving her a PARP inhibitor. But obviously, this is beyond the scope of today's discussion, but worth mentioning how this is all changing very rapidly. So this was my algorithm I presented for the first time last year at SALTI in 2021 or 2020. And certainly this is what we do at our center in clinical practice. So, reflex biomarker testing for PD-L1 would be something when we have a metastatic triple-negative breast cancer patient that we do. Now, which biomarker? Well, this is going to be the topic of today's discussion. So we now have the option of looking at SP142 and or the 22C3 assays, and obviously looking at germline BRCA status if it hasn't already been done. And here, as you can see in the first line setting, we now have two options of nab-pac plus atezolizumab or taxane carbo plus pembrolizumab, which will form the basis for today's discussion. But I wanted to at least comment, if a patient is germline BRCA as well as PD-L1 positive, there is no data on the best approach. And this is a question that I get asked very frequently. Now, I would say that in some ways it's a very practical answer, so that we know that we have data in the first line setting clearly showing benefit of IO plus chemotherapy, but we don't have beyond first line. And so it seems most active in the first line setting, whereas in the data with PARP inhibition from Embraca and Olympiad, we know that these patients seem to benefit better in first line, but there seems to be benefit in second or potentially third line. So that's my personal approach. And then very early on, I think many of us are incorporating molecular profiling for these patients. And if they're obviously TMB high, pembrolizumab is also approved in this, and I'm going to talk a bit about that. So what are the assays we currently have in triple negative breast cancer? So the first, as we know, is SP142, which is looking specifically in the immune cells greater than or equal to 1% and is the companion diagnostic for atezolizumab. Also, we have the 2TC3 assay, which many of you are familiar from the lung literature, CPS score greater than or equal to 10, and is the companion diagnostic for pembrolizumab. Now, when you look at the prevalence of these assays, and this comes from data actually from the Impassion 130 study, but there are other studies out there now as well. So if we have a patient population here looking at the PD-L1 positive cases, how do we compare these different assays? As we know, this is a big problem across many tumor types. So what you can see there, if you're looking at SP142 greater than 1% in the immune cells, that's about 46% of patients, as compared to the 22C3 assay, 81%. Now, the caveat, though, is that when they were looking at greater than or equal to 1%. So what about if we use a cutoff of greater than or equal to 10? And here I think we'd see that the prevalence in the PD-L1 would be a little bit closer to the SP142. Now, what about if we look at these Venn diagrams and how much overlap is there? Well, the first thing you can see here is about 40% of patients will be positive for both SP142 and 22C3. And then there'll be a group of patients that are positive just for 22C3. And as we know, that's because there's a slightly higher prevalence. Now, again, if you're looking specifically at a CPS score greater than or equal to 10, this number will be a little bit smaller. And then there's a smaller group that are just SP142 positive. And certainly, now that we're doing this more reflexively in the clinical practice, I'd have to say that I think that group that are just SP142 positive, I think in my clinical practice, a little bit bigger. Now, what are the ongoing issues with PD-L1 testing? Well, I think the first thing is, education for clinicians and pathologists. The availability of the different machines. As we know, these tests are actually run under different platforms. Training of pathologists around the world. As Peter pointed out, I work in Singapore, cover a vast region. And, just like HER2 testing took a long time to get into routine clinical practice, there are many places around the world that don't have access yet to PD-L1 testing and the pathologists that are trained to do so. Now, in terms of the clinical, there are many assays, different antibodies that are available for immunohistochemistry, different scoring systems. And I think most importantly, these tests are not interchangeable. And so that sensitivity does not mean the same as predictive value. And I'll be talking a little bit more about that. So which PD-L1 test to order? Well, it's quite simple. If you're in the US, you're going to be using the CPS score to look at using the 22C3 assay, as only pembrolizumab is now approved. If you're outside the US, you have the option, depending on your country approval and reimbursement. But if you only have atezo approved, you're just going to be looking at SP142. But if both approved, you can also use the CPS score. Now, going back to this patient. So what site should I test for in PD-L1? And we have increasing data that tells us that in the primary, we're much more likely to find a positive PD-L1 test, around more than 60%, versus the metastatic site, around 40%. And again, many data sets have also showed us now that we're less likely to find a positive rate in liver, bone, and skin is a little bit more controversial. So in this particular patient, if you see she's got new liver and lung lesions, you want to first make sure you do a biopsy, confirm that this is cancer. Number two, you want to repeat your ERPR and HER2 testing. And then finally, you want to do your PD-L1 testing. If it's negative, then you have the option of potentially going back and checking the primary. Now, what data do we have on looking at the primary? Well, what's interesting, again, this is data from Impassion 130. You can see that about 60% of the patients on that study, the PD-L1 testing comes from the primary, about 38% comes from the metastatic tissue, and you can see, not surprisingly, higher rates of PD-L1 positivity if you're measuring it in the primary tissue. And then looking at the PD-L1 status by anatomical location, higher rates of PD-L1 positivity in terms of the absolute positivity in the lymph node, in the lung, and lower, as I mentioned, in the liver. Now, does the site affect your efficacy if you're using immune checkpoint inhibition? And this is, subgroup analysis, smaller numbers, but not surprisingly, it does suggest that you might have a more robust benefit if you're getting that PD-L1 testing from your metastatic lesion, a hazard ratio of 0.55 versus 0.79 if you're getting that biopsy from the primary site. But again, this is subgroup analysis. It still seems to benefit regardless if it's in the primary or metastatic. So in your patient, ideally you get it from metastatic. If it's negative in the metastatic, I am going back and actually checking it in the primary. And I know that many of us in the field have been discussing this because I think, there is so much room to grow in terms of still identifying which patients are more likely to benefit. So these are the recently published guidelines from the Society of Immunotherapy for Cancer, first author Alicia Emmons, and these are the panel recommendations for biomarkers in breast cancer. So as I mentioned, all patients with advanced TNBC should have tumor tissue tested for PD-L1, TMB, and MSI by FDA-approved tests. All patients who are candidates for immunotherapy should have tumor tested for PD-L1 at least once, irrespective of prior therapies. Now, most importantly, as Heather McArthur is going to go into, PD-L1 testing is not recommended for patients with early stage breast cancer at this time because the results seem to be independent of PD-L1 status. When you're considering metastatic sites to test for PD-L1, it is preferable to prioritize extrahepatic sites or the primary tumor, as I mentioned, if available. And that biomarker assessment, including repeat receptor profiles, PD-L1, and NGS should be considered at the time of first relapse. And especially if the patient has had neoadjuvant therapy where they would have been exposed already to multiple agents where, it is important to profile these patients, potentially get them on trial as well. So what data do we have? Well, the first, as we know, the first proof of concept was data from the Impassion study that was presented first by Peter Schmidt and then published the overall survival by Alicia Emmons in the Annals of Oncology this year. And as many of us know, this was a large study, almost 1,000 patients that were randomized with metastatic triple negative or unresectable locally advanced breast cancer to receive either nab-paclitaxel plus or minus nab plus atezolizumab. Stratification factors were liver, prior taxanes, and then PD-L1 status. Now here, PD-L1 status was the Ventana assay using SP142 in the immune cells. Now it's important to mention that the co-primary endpoints were PFS and OS, and the hierarchical testing was designed such that they were to look at the ITT and PD-L1 IC populations following that. So you won't see the p-values because of this study design. But what you can see here is the overall survival in the PD-L1 positive immune cell population increased from 18 months to 25 months with the addition of atezolizumab, hazard ratio of 0.67, and there are the confidence intervals. Now, I think we were all anxiously awaiting the data from Impassion 1331 because not everybody has access to nab-paclitaxel. As we know, it's a bit more expensive than solvent-based paclitaxel. Now, Impassion 131 was a very similar design with the substitution of solvent-based paclitaxel for nab and a 2-to-1 randomization. And what you can see here is that, unfortunately, there was no improvement in PFS, no improvement in overall survival, either in the ITT or in the PD-L1 positive population. So what I think is important is that really this highlights some of the nuances and some of the issues with ongoing trials in triple negative. Are these conflicting results? Why are we seeing these differences in terms of improvement with immune checkpoint inhibition? So the first thing I really want to highlight is that if you look at the control arm of Impassion 130 and you look at the overall survival in the PD-L1 positive IC population, what you can see here with the addition of atezolizumab, it was 25 months. So that's the experimental arm of 25 months. Now, contrast that with Impassion 31, where the control arm of that trial, that we're just getting solvent-based paclitaxel, we see an overall survival of 28 months. So historically, we've never seen a survival with solvent-based paclitaxel of 28 months. And so I think, again, like I said, it highlights the heterogeneity of triple-negative breast cancer. So you just don't know which groups of patients are potentially entering into these different trials. We also saw, which we're going to see in Keynote 355, the solvent-based paclitaxel and pembro arm overall survival was 21 months. And so we also know in trials of immune checkpoint inhibition, we can't control for all the unknown and known confounders. That's just not part of what we do, such as antibiotic use, the microbiome, and things like PTEN status, which may actually serve as a mechanism of resistance. So this is why the Keynote 355 study is so important. And here they looked at standard chemotherapy, which could include a taxane or gemcarbo, plus or minus pembrolizumab, which is, as we know, a PD-1 inhibitor, a 2-to-1 randomization, a DFI of 6 months or more. They looked at stratification by PD-L1 status, but this was looking at the CPS score using the 2TC3 assay. And what we know is that the stratification factor was CPS greater than or equal to 1. But again, there was an amendment in the protocol then to plan to look at the CPS scores greater than equal to 10 based on some of the other literature and other tumor types. And this is data presented and published by Javier Cortez in the Lancet last year. And what you can see here in terms of the patients, that about 45% of the patients received a taxane, which could have included nab-paclitaxel or solvent-based paclitaxel. About 55% of the patients received gemcarbo. And importantly to mention is the DFI, the disease-free interval. So about 20% in each arm had a DFI of less than 12 months. And this is important because often these patients are excluded from trials, but in this study, 6 to 12 months, the patients were allowed on study. And about 50% of the patients had a DFI of greater than or equal to 12 months. These are the data that were initially presented looking at progression-free survival. And what you can see here is in a CPS score greater than or equal to 10, a robust hazard ratio of 0.65 with an improvement of 5.6 to 9.7 months in terms of PFS. Now, these curves separate very early, and as you can see, they continue to separate. Now, what you can see in the CPS score greater than or equal to 1, the results here are a little bit more modest, hazard ratio of 0.74. And what's interesting is you can see that the curves separate there later and don't actually widen quite as much as we see with the CPS score greater than or equal to 10. Now, I think we're all very excited to see the data of the overall survival presented at this year's ESMO, but also at this year's San Antonio meeting by Javier Cortez. And what you can see here is an improvement of 16.1 months in terms of overall survival, is what we would expect from solvent-based paclitaxel, which increases to 23 months with the addition of pembrolizumab, hazard ratio of 0.73, and p-value of 0.0093. But what we'd all like to know is, what is the ideal chemo backbone? And what we realize now is that, in fact, chemotherapy has a very important immunomodulatory effect on the microenvironment, such that can actually prime the immune system. And different chemotherapies may have differential effects in doing so. So this was a really important trial presented by our colleagues in the Netherlands that looked at different types of chemotherapy and their potential ability to prime the immune system. And you can see there that anthracyclines and platinums were especially able to prime that response. Now, this is a small study, but you can see also here looking at the data from Keynote 355, and this was initially presented by Hope Rugo last year, that shows us the different results in the subgroups by on-treatment chemotherapy. So I just want to bring this forward because this is looking at the PD-L1 CPS score greater than or equal to 10. And what you can see here is across all of the unstudied chemotherapy, there seemed to be a benefit of adding pembrolizumab. And this includes solvent-based paclitaxel 3.6 to 9.6 months, hazard ratio 0.33, hazard ratio for nab-paclitaxel 0.57. And then I think what you can see here is, again, there is an improvement with gemcarbo. This is a subgroup analysis, but does seem to be a bit more modest. Is that because gemcarbo on its own is such a powerful regimen? But I think we're also quite keen to see the overall survival data by chemo backbone, but it does seem to mean benefits across these different chemo backbones. So which chemo backbone? Well, let's go back to our case. So in this clinical scenario where patients have had prior taxane, platinum in the neoadjuvant setting. Now, I think many have not been using a taxane or using a platinum. But now with the brightness data and certainly incorporating it in Keynote 522, I think many people are. This patient had a DFI of about 18 months. As I mentioned, we can reflex test for both. And so she had an SP142 of 10% that was positive and a CPS score of 20. So for her, longer than 12 months, we can consider a taxane, either type of taxane plus pembrolizumab or nab-paclitaxel plus atezolizumab. As I mentioned in Keynote 355 and in Passion 130, these patients included patients with taxanes in the adjuvant setting greater than 6 months or 12 months respectively. But I think you can consider carbo-gem plus pembro. I think the real question is, what is the role of rechallenging with platinum? We saw with Keynote 355, there were about a quarter of those patients that had had their prior chemotherapy, but we don't know the nuances of how many patients, but certainly not as much data of rechallenging with platinum. But I think it's also important to consider the patient preferences. I know in my practice, especially with a short DFI, there's a tremendous interest in preserving hair loss. We can use a cold cap, but also what if the patient has pre-existing neuropathy? Now, if the patient has a DFI of less than 6 months, this is a data-free zone. If the patient's chemo naive, though, de novo first-line metastatic triple negative, and as we know, this is actually a much larger percent of the patients that make up our clinic now, there is no known best chemotherapy backbone at present. And again, patient preferences do have to come into play. So, I've had this come up a lot in clinical practice. So I tried to sort of put this in an algorithm that worked for me that I think is always hard to translate into a guideline. But certainly if you're working in outside the US and you're doing an SP142 test, it's really quite easy. DFS greater than 12 months, your only option is atezo plus nab-paclitaxel. If you have a DFI of less than 12 months, this is a data-free zone. We do have the ongoing Impassion 132 study, which is looking at carbogem or K plus or minus atezo, which currently is recruiting only to the PD-L1 positive population. In those patients, though, that have CPS scores greater than or equal to 10, I think if you have a DFI of less than 6 months, this is a data-free zone. I think it's very reasonable to consider, let's say, nab-pac plus pembrolizumab, but we don't really have data for those patients. If a DFI is 6 to 12 months, if they've had no prior platinum, then I think gem carbo plus pembrolizumab is a nice option for these patients because they won't have seen that chemo backbone yet. If they've had a prior platinum, I guess my preference really is to use nab-pac plus pembro, and that's because we know that nab-pac is not completely cross-resistant with solvent-based paclitaxel. It's a very sort of well-tolerated regimen in my practice. You don't have to give steroids. And then I think the other thing is we know in hard-to-treat cancers, nab-paclitaxel is a very active agent. For a DFI of greater than 12 months, I think you can give taxane or gem carbo plus pembro, but again, patient preferences will come into play. And obviously reimbursement in whatever country that you're working in. What are the predictors of the immune response? So obviously the one we know the most that's approved around the world is looking at PD-L1 status. Most importantly, though, I think there's emerging data looking at TMB. And I think we saw some approvals for pembrolizumab looking at TMB greater than 10, but we know that this was not well presented with breast cancers. More recent studies have looked at the support of benefit of pembro with TMB greater than 10. But I think one of the issues is that we don't know the right cutoff for TMB for breast cancer. It might be different. And there was recently data presented published from looking at atezolizumab. And here this was a multiple basket study, but looking at atezolizumab, a phase 2 study, and here's looking at TMB. So there were two groups, greater than or equal to 10, less than 16, and then TMB greater or equal to 16. And you can see that the median PFS was much more robust when they were looking at the TMB greater than 16. You can see here PFS, and this is the overall survival. So again, this is included many tumor types, but I think not surprisingly, the higher TMB, the more likely you are to elicit a better signal in terms of efficacy. Now, what do the guidelines say? So this is the, as I mentioned, the guidelines earlier, and these are the FDA-approved immunotherapies for advanced TNBC. So pembro plus chemo, CPS score is greater than or equal to 10. You can use 200 every 3 weeks or 400 every 6 weeks, and this is important when you're on the maintenance phase, but also approval for MSI, TMB high tumors, again, the same regimen, and then formally approved regimen atezo plus nab. I wouldn't give solvent-based, and then PD-L1 greater than or equal to 1 in terms of the immune cells. This is mirrored by the NCCN guidelines that were just published. again, looking at TNBC, this mirrors really the immunotherapy guidelines that you just saw. And as I said, that's TMB high. They're looking at greater than equal to 10 as an approval. But again, this is a moving target as we do more studies in breast cancer. Now, looking at the more recently published ESMO guidelines, again, patients with triple negative breast cancer, if they're PD-L1 positive, if you're working outside the US, you have the option of giving either atezo, nab-paclitaxel, or pembrolizumab plus chemotherapy. Similarly, the ABC6 guidelines highlight the same concepts. So in your country, pembrolizumab plus taxane or gemcarbo, or atezo plus nab-paclitaxel. And finally, it's important to recognize some of the different toxicities that we may see with immunotherapy. I think over the years at this meeting, we've seen many talks about how to manage immune checkpoint inhibition. And here you can see about 5 to 10% rates of grade 3 or more immune-mediated adverse events. And so I would really urge you to go to a lot of the guidelines that have been published, because there are many out there. It really sort of highlights how easily managed this is if you know about the side effects, you know how to address them, early sort of addressing of these issues with corticosteroids, and getting a multidisciplinary team involved. So this is my summary of immune checkpoint inhibition in metastatic triple negative. So first, the results are quite consistent. We have 2 randomized phase 3 trials confirming the overall survival benefit of atezo and pembrolizumab in triple negative breast cancer. But I think it's absolutely crucial to mention that PD-L1 status by immunohistochemistry is a requisite companion diagnostic in metastatic triple negative. So you must use the PD-L1 result relevant to the therapeutic agent. So SP142 for atezolizumab greater than equal to 1% in the immune cells, 22C3 CPS score greater than equal to 10 for pembro. We all think there likely is a better biomarker, and that research is in progress. What is the best chemotherapy backbone? Well, if you're using atezo, the data is only with nab-paclitaxel. It's not approved in the US. But if a patient is on atezolizumab and they're in the US, the recommendation is to continue if they're getting ongoing benefit. If you're using pembrolizumab, the data suggests that you can use either type of taxane or carbogem. But again, be aware of the unique side effects and follow the guidelines for IO toxicity. And I want to highlight this recent brilliant review by Gianpaolo Bianchini and his colleagues, really walk us through and help us understand the immune portrait of triple negative and how complex it remains. And so what you can see there is that's clearly beyond just looking at PD-L1 status. And I think it's also important to recognize the impact of tumor evolution on the biology of these tumors. And so the response to immunotherapy is likely a complex interplay. And in breast cancer, that might be slightly different. And this is the blankogram. So really considering things like the APOBEC signature. And again, recruit our trials wherever possible to immuno-oncology trials. So with this, I want to finish. I think Heather MacArthur is going to walk us through the neoadjuvant setting. But I think there's some interesting data published and presented at this meeting. I think looking at the very exciting concept of looking at spatial immunophenotypes. Now, this is an expensive and a little bit more difficult to do, but I think it really highlights to us that we do have an ability potentially in the future to better refine our ability to identify patients that might benefit from IO. And I'm very pleased to hand over to my colleague, Dr. Heather MacArthur. And I want to thank the many colleagues around the world for their sharing of slides, sharing of ideas as we work through this very exciting field in the treatment of triple negative breast cancer. Thank you.